Welcome, everyone. I'm Mike Knoppen. I am the Program Director for the Myotonic Dystrophy Foundation. Welcome to today's Ask the Expert series on COVID-19 and vaccines. Briefly about the Myotonic Dystrophy Foundation. Our vision is a world with treatments and a cure for myotonic dystrophy. Our mission is a community care and cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care. We accelerate research toward treatments and a cure. We provide a number of additional resources and support opportunities for all individuals affected by myotonic dystrophy and families. You can find our toolkits and publications on our website. You can visit virtual support groups and Facebook chats to connect with other members of the community. You can find our full calendar of events online, and you can access our digital academy with presentations and videos from past events. I want to let everyone know that this session today is being recorded, and it will be posted to the MDF Digital Academy, which you can access at myotonic.org/digital-academy. Because today's presentation is about COVID-19 and vaccines, we want to direct you to MDF's other COVID-19 resources. You can find those at myotonic.org/COVID-19. There you will find FAQs about myotonic dystrophy, COVID-19, and vaccines, and you will find care recommendations for individuals living with myotonic dystrophy. It is now my distinct privilege and honor to introduce you to our panelists. First, we'll be hearing from Dr. Mankodi, who's a principal investigator at the NIH, whose research goals are to study disease mechanisms and develop treatments in hereditary skeletal muscle diseases. Welcome, Dr. Mankodi. Aruna Subramanian is a clinical professor of infectious diseases at Stanford Healthcare. She cares for immunocompromised patients with infections and has been involved in COVID-19 care and research since March 2020. Dr. Robert J. Graham is a senior associate in critical care medicine, Department of Anesthesiology, critical care, and pain medicine, and an associate professor of anesthesia at Harvard Medical School. He's the director of critical care anesthesia, perioperative extension, and home ventilation program. Welcome, Dr. Graham. And last, we will hear from Dr. Hank Meyer. Dr. Meyer is an attending pulmonologist and director of the Pulmonary Function Laboratory at the Children's Hospital of Philadelphia. As you heard, we have experts in a number of fields with tremendous expertise in clinical care who have been treating individuals living with myotonic dystrophy. We have pediatricians and adult care experts, and we will hear from them now. First, we will hear from Dr. Mankodi. Dr. Mankodi, hello. You have the presentation skills now. You can share your presentation with us. Thank you so much.
Thank you. Hello, everyone. Can you see my screen?
Yes, it looks great. Thank you.
Cool. So I'm going to be talking a little bit about myotonic dystrophy and COVID-19. Just get us all started with the background information. So myotonic dystrophy is a multi-system disease, and it is caused by defects in two genes that are shown on this slide. There is an expansion of repeats with shared CTG sequence. Clinical features overlap between the two types of myotonic dystrophy, or DM. DM type 1 or DM1 can be more severe. It can manifest right from birth to old age, and it can involve multiple systems. In contrast, DM type 2 manifests only in in adults. There are no cases of DM2 in children. I should correct myself. It is less severe than type 1, and fewer systems are involved. In particular, respiratory system involvement is uncommon. There is now consensus in the field that DM is caused by disturbance in the processing of RNA. Now, expanded repeat in the DM genes is not related to RNA present in the COVID-19 virus or available RNA vaccines. It is not expected that the DM mutations would affect the mRNA in the virus or the vaccines. We all are aware that coronavirus 19 or COVID-19 has affected millions of individuals around the globe, as evident from most recent map from Johns Hopkins University website. However, what is working in our defense in 2021 are vaccines. So you can see from the plot on your right, the green line represents individuals who have received vaccines. The blue lines are individuals who have yet to receive vaccine. And the chart shows the hospital admission rates. You can see that individuals who have received vaccines are significantly less likely to be in the hospital compared to those who have yet to receive vaccines. We are familiar with the illustrations of COVID-19 virus. Its scientific name is SARS-CoV-2. It's shown in the top panel. It's a spherical molecule, and it has the protruding part, which is known as spike protein, which are shown here in red color. The spikes are the ones that viral particle use to attach to the cell, get inside our cell, use our cell machineries to their benefit, multiply, replicates, and as you can see in the bottom panel, it's a live electron microscope showing multiple viral particles emerging from the host cell. As the virus circulates more and more, it replicates more and more, the genetic material of the virus changes. These are known as mutations. A virus with one or many mutations is called variant of its original form. We are familiar with Delta variant, which is the predominant variant, and Omicron variant, which is just emerging. Why these variants are concerning? Because they can change the clinical disease, make it more severe, and spread the infection more easily. How does COVID-19 spread? So COVID-19, we all know it spreads through air particles, known as aerosols or droplets, through direct physical contact with infected individual, or through common contaminated surfaces that are not cleaned or disinfected. It is important to remember that people with no symptoms can spread the virus. What are the common symptoms of COVID-19? These are shown on this slide. Cough, shortness of breath, fever, body aches, muscle pains, vomiting, diarrhea, new loss of taste or smell. Fortunately, a large majority, about 80%, I read somewhere the figure that they have milder disease and they can recover at home. 1 in 5 are admitted in the hospital and 5% need intensive care. The warning signs, remember to call 911 when symptoms of breathing trouble, chest pain, confusion, drowsiness, or discoloration of lips, nail beds, skin occur, because these are indicators for serious disease. COVID-19 can affect breathing in all, including young, healthy individuals. Primarily, COVID-19 infection involves lungs. Most commonly, both lungs are infected. The air sacs are filled with the fluid, limiting the ability for the body to take in oxygen. Individuals will manifest with shortness of breath, cough, high-grade fevers, and other symptoms of pneumonia, requiring hospital admission. As pneumonia advances, lung failure can set in, requiring ventilator to help oxygen levels in the body. Unlike COVID-19, myotonic dystrophy does not cause major changes in the lungs. The breathing problems in some individuals with myotonic dystrophy type 1 are due to weakness of breathing muscles, the diaphragm, the chest wall, and the abdominal wall muscles. Weakness of the swallowing muscles and foot pipe muscles. This muscle weakness can all lead to increased risk of pneumonia. In addition, there are sleep-related breathing disorders in some individuals with myotonic dystrophy, and that can cause increase in carbon dioxide or CO2 and low oxygen levels. If not attended to in time or recognized, they can lead to secondary complications, including some heart conditions. Important point to remember is that when oxygen supply is needed in an individual with myotonic dystrophy, fortunately, we haven't heard of any individual with myotonic dystrophy with COVID-19, but if it is needed for any reason, maybe pneumonia, it is important that oxygen is given through devices such as positive airway pressure or double lumen compatible ventilator. It is recommended to remember the setting if the devices are used at home. There is increasing concern that breathing devices used at home, there are chances that it can increase the spread of virus in COVID-19 pandemic. Myotonic Foundation, with the help of experts, have set up recommendations to limit the spread, and they are available on the website. Important points are listed on this slide. The face mask should be full covering nose and mouth, no ventilation port, double lumen compatible devices, or put a filter on the CO2 exhalation port. There should not be any leaks, and devices should be cleaned and disinfected as per recommendations by medical team. For caregivers and family members who are helping, caution should be exercised for hand hygiene, protective gear, social distancing, cleaning and disinfecting the devices and surfaces. Some words about heart. COVID-19 in severe illness form can infect heart muscle called myocarditis. More common than this are clotting of the blood vessels that supply blood to the heart muscle, causing heart attack. And it can cause impairment of the heart muscle function called heart failure. Myotonic dystrophy affects heart, mostly the electric cable shown here in yellow. It's known as conduction system. There is slowing of the function of conduction system that can result in abnormal rhythm. It can be detected by ECG as shown. An example is shown on this slide. Heart function can be impaired too. Regular evaluation and prevention through proper management are key because they can be life-saving. Some of the common symptoms are listed in the yellow box on the slide, such as feeling of own heartbeat, dizziness, fainting, or passing out. However, even if symptoms are not present, it is recommended that regular evaluation is followed. Interestingly, some healthy individuals after COVID-19 infection have gone on to develop diabetes. We now know that COVID-19 can infect and impair insulin-producing cells in the pancreas, resulting in diabetes. We are aware that myotonic dystrophy can impair insulin function and cause diabetes, abnormal lipid profile, and fat distribution. But I should note here, there are other factors such as stress, physical inactivity, food choices may also play a role in metabolic syndrome. This slide lists conditions that are associated with increased risk for serious illness from COVID-19. Please note that these conditions are not specific to myotonic dystrophy. Some of these are metabolic syndrome, heart condition, lung condition, kidney condition, diabetes, which is poorly controlled. In summary, there is not much information about how people with myotonic dystrophy type 1 and 2 respond to COVID-19. Individuals who have weak cough, breathing troubles, poorly controlled diabetes, heart condition may be at increased risk for serious illness from COVID-19. What defenses do we have? Optimize healthcare with the help of medical team. Lifestyle changes and proper medical care can improve overall health, and therefore the viral pandemic, current as well as future, can confer less threat. Best defense we have are vaccines. I'm going to pass on the baton to my colleague, Dr. Subramanian, who's going to tell us more about vaccines.
Thank you so much, Dr. Mankodi. Let me share my screen. So it's an honor to be here to talk to you about COVID-19 and vaccines. I know there have been lots of questions about vaccines and concerns, rightfully so. So people really want to know information about the vaccines and make sure that they're making the right choice. The amazing thing, as Dr. Mankodi said, is the vaccines are here to protect us. And there's been such a wonderful uptake globally. If you can even imagine this number, it's so hard to even take in. 8.28 billion with a B doses have been administered globally. 55.3% of the world has received at least one dose. There are concerns about vaccine equity and other things we could address at a different point in time. But the amazing thing is that when you've given the vaccine to so many billions of people, we can be really reassured as to their safety. Unfortunately, sometimes the media really focuses on one or two unusual events, or people report things that may or may not even be related to the vaccine. But I think we can all be reassured at the numbers of folks who are getting vaccinated and its rollout. But how do these vaccines work? The coronavirus, SARS-CoV-2, as Dr. Mankodi said, has these spike proteins. You'll see in the first panel, these red T's around the virus. That is what attaches to the cells in our body. In the lab, scientists have constructed mRNA, which has instructions or code for making that spike protein in your body. This mRNA is packaged into a fatty packaging. It's made with lipids. And then that's injected into your arm. That packaged mRNA then attaches to dendritic cells, or a part of the immune cell, and goes into the cytoplasm of the cell. You can see in panel 3. This mRNA only stays in the cytoplasm. It does not go into the nucleus. It does not interact with the DNA inside our cells. It cannot change the DNA. It doesn't interact with any of the abnormal RNA repeats from that are seen in DM. And it really only goes to the ribosome where proteins are made. That code is read in the ribosome, and the spike protein is created inside the cell and then put on the surface of the cell, you see in panel 4, where your own cell will then have a spike protein on the outside. That allows our immune system to then recognize that as a foreign protein and make defenses. So antibodies, memory B and T cells are then made so that if you ever see this spike protein again, if you see the coronavirus in real life again, these antibodies will give you immunity. They'll bind to those spike proteins on the surface of the coronavirus, as you see in panel 6. So I hope this sort of explains how the mRNA vaccines work. It's actually a very simple technique, and it doesn't involve the nucleus, as I said. It doesn't involve our DNA, and it doesn't change our RNA in any way. This mRNA then gets degraded naturally, and the spike proteins also get degraded. What's left are the antibodies and those memory B and T cells in our immune system that really give us that protection from severe disease. Viral vector vaccines actually work in a similar way. The gene from the virus that encodes the spike protein is taken from SARS-CoV-2, and that genetic material is then inserted into a harmless, unrelated virus vector, usually adenovirus. And it's not the type of adenovirus that makes you sick. It's a harmless type of virus. Then that is packaged and injected into your arm. And then that virus enters the cell. Again, proteins are made based on that code. The spike protein is put on the surface of that cell, and antibodies and immune cells, memory T and B cells, then create the defense against future infection. So very similarly, this also does not interact with our DNA and is really meant to make this protein temporarily so that our immune systems can recognize it. There is a theoretical advantage of using an mRNA vaccine that Dr. Graham will talk about later. But if you've already gotten a viral vector vaccine, I'll talk about boosters. So these vaccines are extremely safe. They're some of the safest vaccines we have available. As I said, mRNA does not enter the nucleus. It cannot change our DNA. And these vaccine components are not known to interact with the RNA repeats that we know are present in DM. Really, as Dr. Mankodi said, the risks of COVID for people with DM, especially if there are breathing problems and others, are much greater than the risks of vaccines. People can get very ill from COVID-19, and we want to do everything we can to protect our loved ones so that they don't develop COVID-19. The other question we got was whether boosters are still recommended even if you've had natural infection. And yes, boosters are recommended even after natural infection, because boosters or vaccine plus natural infection actually gives you an even wider repertoire of immune response. So you have even better, wider protection to this to COVID-19. Sorry. So what are the schedules? What's recommended for the schedules and boosters? Primary series are what was recommended first, and that's for most people, that's 2 doses of vaccine. So for children aged 5 to 11, 2 doses that are 21 days apart for the Pfizer vaccine are recommended. If you're over 12 years of age, then that's the same recommended timing, though the dose is a little bit higher. For Moderna, it's a 28-day interval, and for Janssen, or J&J, it's only 1 dose. The majority of our patients with DM are not considered moderate to severely immunocompromised, so they don't need an additional primary dose, but boosters are recommended for everyone, especially now with new variants coming out. So if you've had your 2 doses of Pfizer 6 months ago, you should get a booster, same with Moderna. And if you've had the J&J vaccine 2 months ago, you should get boosted. And I would recommend that you get boosted with one of the mRNA vaccines, because that mix and match approach is even better and gives you even better protection than just using the J&J alone. What about the Omicron variant and vaccines? There's a lot of concern and confusion, and people do need to stay tuned as we're learning more and more about this. The efficacy of our vaccines is being studied in Omicron. But the bottom line so far is that vaccines likely still give us good protection against severe disease, even with the new variants. There's some early data that there's possibly less what's called neutralizing activity in the lab against the new variants. That means the antibodies may not bind as well or prevent binding of the virus to cells as well. But what we really need to wait for is the correlation of these results in the lab with real-world outcomes, because there are other parts of the immune system, those memory cells, that may still work very well. There's also a signal that boosters may help with the vaccine efficacy. So if you haven't received a booster yet, I would highly recommend getting that. Even if you're vaccinated, you can still get mild disease. So if you're vaccinated and get exposed, you should call your doctor or your care team, get tested soon, and ask about options for outpatient treatment. Now we have options for outpatient treatment, which include monoclonal antibodies and sometimes pills that are coming soon. And treatments are still likely very effective if you get the disease. Studies are underway. But the most important thing is that we're trying to focus on prevention. Prevention is so much better than actually having to treat the disease. So if you have the opportunity to get the vaccine, please do. An ounce of prevention is worth a pound of cure. Thank you very much. And I will stop sharing and turn the screen over to Dr. Graham.
Thank you, Dr. Subramanian. I'm Dr. Robert Graham. I'm actually a pediatric intensive care provider. And you might ask yourself, why is a PICU doc talking about vaccines? Well, in fact, actually, I was at a world conference in 2004, and Frank Shan, who's a preeminent pediatric intensivist at that time, gave the keynote speech on how much resources we could divert that we're providing in the pediatric ICU setting. If we diverted that to vaccines, we could probably, address far more disease far more efficaciously worldwide than in any single ICU. And so I think this is rather prescient at this point when we're dealing with this pandemic. So specifically though, with regards to why an ICU doctor is talking to you about vaccines, it's because they're so important. I mean, we do see acute COVID infections in children. It's very uncommon. And actually, Dr. Subramanian, as someone who focuses on those individuals with immunocompromised states, can speak to that. That these are often children and young adults who have other underlying conditions. Not necessarily myotonic dystrophy, because as we know, the immune function is okay. But it is something to be aware of, that even previously healthy children do get acute COVID. In the ICU setting, though, one of the things that we are most acutely aware of is this syndrome called multisystem inflammatory syndrome in children. It's unusual. You may have heard about it on the news and otherwise as a Kawasaki-like syndrome. It's thought to be an inflammation, the body's response, but later to COVID. That these are often children who may have been exposed months before, weeks to months before, may have known that they had it, or may have been asymptomatic and cleared the COVID virus itself. But it triggered an inflammatory sort of cascade, a domino effect that's affecting multiple parts of their body. They come in with fevers, rashes, eye changes, and for those who wind up in the ICU, it's because they can actually have heart failure. And so it's something that we're very acutely aware of, and we also know that the vaccine is helpful at mitigating that. The other reason is that we know that children who have COVID-19, whether they're symptomatic or not, share it with everyone. Kids share lots of germs. And, this is of consequence to family members, schoolmates, grandparents, other people in the community. And so it's something that we would really encourage, because we don't want to sort of, have others exposed. And then many of you may have also heard, our hospitals are full. You hear about it on the news, and the fact is it's a reality. We are full with COVID in the adult hospitals. We are full with some MISC, and then just general illness in the pediatric facilities. And this has implications not just for COVID care, but for everything. I mean, if you come in and you need care for any illness, whether it's heart-related or strokes or just regular pneumonias or even trauma. You're in a car accident. When hospitals are full, it puts everyone in crisis. And so it's something to think about. What could we do to prevent these things and help sort of healthcare provision overall? And that is the vaccine. Vaccines work and they are safe. So in preparation for this, I actually wanted to look specifically, is there anything about myotonic dystrophy that's been published? And there really isn't a lot, but it is helpful to sort of appreciate that people are focusing on this, and not just, myotonic dystrophy, but other neuromuscular conditions. Tony Amato, who's a neurologist for adults at the Brigham and Women's Hospital, and another colleague, wrote a commentary actually just at the beginning of the pandemic, saying that we should focus on neuromuscular disease as a risk factor. Not so much in the sense that we think about diabetes or the other things that Dr. Mankodi mentioned, but just that these are people who have weakness and respiratory difficulties at baseline. And if you think about myotonic dystrophy, it would fall into this muscle disorder that I highlight in yellow down below. There are lots of neuromuscular diseases, but what Dr. Amato highlighted is that, it's the range, that we know that individuals with myotonic dystrophy don't all look the same. And so it probably is more about the individual than the condition itself. And so something to be aware of. There is a small case series out of Belgium. This is the second citation at the top there by Don't and colleagues, where they actually described 4 individuals with myotonic dystrophy who wound up hospitalized and quite sick with COVID-19, again, early in the pandemic. All of these individuals were over 40 years of age, and actually all of them had other comorbidities, other complicating factors, as was highlighted in the prior presentation. So it's something to think about, is that it's the myotonic dystrophy we want to be cautious about, but it's the other conditions that we need to also take into account. So as Dr. Subramanian reviewed, and I won't sort of belabor this, we have a couple of different approaches in terms of the vaccines, and both are very efficacious. So you have the mRNA vaccines, then you have the adenoviral vaccines, and I'll talk a little bit about potential implications for myotonic dystrophy in particular a little bit later on. The fact is, we actually haven't seen a lot of COVID-19 in the neuromuscular community overall. I think all of us know of colleagues who've cared for them, or for families and actually children and even adults who have been affected, not necessarily with myotonic dystrophy, although there was that publication that I reviewed, but with other conditions like Duchenne's muscular dystrophy, spinal muscular atrophy, other things. But the fact of the matter is, most individuals with neuromuscular conditions like myotonic dystrophy have been cautious from the outset. And the fact is, I think it's that you took the precautions you needed to. There was quarantining, there was hand washing, and even if you became sick, you had the tools to help yourselves at home. And I think Dr. Meyer is going to be speaking a little bit to that as well, in terms of what are the types of interventions that we like to utilize for protecting lung and supporting breathing, the oxygen and the carbon dioxide and otherwise. I think as both the prior presentations highlighted, the best defense is a good offense, and that offense is vaccination. So I borrowed this table and modified it a little bit from a colleague, Ofer Levy, who's an infectious disease specialist. He and another colleague actually wrote this nice sort of opinion piece as to why they might think or recommend mandatory vaccination or immunization in pediatrics for COVID-19. So what I've done here is, in the red little or pink boxes that you can see, it sort of highlighted some of the key takeaways, but then I also added the little emojis, the little green person, the purple house, the town, and the world, to sort of highlight, how does this impact us? How would vaccinations, what does it mean to me as the individual? What does it mean to my friends and my family and the people in my town and what have you? And I think it's easy to sort of look at these one at a time. As I said, COVID-19 acutely is uncommon in children, but the vaccine prevents that. And then COVID-19 will presumably as well, there's evidence to suggest that it prevents the MISC, this inflammatory syndrome, which is of great consequence. When you think about our friends and families, children who become infected, they excrete the virus. That can infect their parents, it can infect their grandparents, teachers, other children in the household. So siblings, it's important to vaccinate siblings. And again, because they're asymptomatic, other precautions aren't necessarily going to suffice. Hand washing, we know kids aren't necessarily great at. Mask wearing is highly variable. Some children just don't tolerate having them on. And so vaccination is our best offense, as I said. And I think as Dr. Subramanian, actually everyone's sort of spoken to so far, is that the strains can change. There's the mutations, the variants that we're all dealing with. And in fact, actually, there will be cross-reactivity, and there's evidence to support that, whether it's the Delta variant or the Omicron variant that we're seeing, or undoubtedly the new variants that will follow. That adding the vaccine will help in terms of, at least decreasing how severe an illness may be. It's not that you won't get infected, but it'll decrease the likelihood of needing hospitalization or even really getting that sick in the home care setting. At the beginning of the vaccination process, we heard a lot about herd immunity, and we actually haven't heard about that much lately, but I'll talk about that when I look at the numbers of patients, number of people that have been vaccinated so far. And ultimately, our goal is to actually normalize our lives, and that vaccination, mass vaccination, will be the only way to sort of get back to school, get back to work, and normalize our activities as we remember them. So if you're interested, you can go to the CDC website. I actually just downloaded all of this information just last Thursday in preparation for this talk. It's actually really easy to sort of find this data, and I think this is helpful. And Dr. Subramanian actually talked about the 8 billion people vaccinated worldwide so far. This is actually interesting when you look at it, and this breaks it down by year, like how old you are in sort of little divisions, and how many people are vaccinated. And you can see when the vaccines first came out in sort of December 2020, and then you see an uptick in January 2021. We see an uptick across all the age groups. Now, in the 65 to 74-year age group, as of last Thursday, 99.9% of the population in the United States has had at least one vaccine. That is amazing, and that's where we want to be. Now, you can look at the other age groups, and as we think about children, the 5 to 11 years were just approved, and the 12 to 17 had previously been approved. And you can see, we're achieving some, success in getting them vaccinated. About 15% of the children 5 to 11 in the United States, that's over 4.5 million children, have been vaccinated with at least one dose. And over 60% in the 12 to 17 range have been vaccinated. That's over 15.5 million. So there are no specific studies looking at myotonic dystrophy and the vaccine, but you can assume, as there are with other neuromuscular conditions, that a large number of individuals are embedded in that. If there are 15.5 million adolescents who have received the vaccine, there are definitely some with myotonic dystrophy in there. So people are always wondering what are complications that can happen with vaccines, and this is one of the things that we're often helpful to talk to your team. And this is one of the takeaways: talk to your team, your primary care doc, your neurologist, your respiratory provider, whomever you really connect with and can be informed about what to expect. And that can happen before the vaccine or after the vaccine if you have questions. Now, a large number of people will have some sort of response. Little fever, they may feel aches and pains, they just might not feel well. They feel like they have, that they're sick. And that's often the case even with the first dose and more common with the second dose. Ranges in symptoms from having none to about half the people report something, including a headache or maybe just sort of general fatigue. That tends to go away very quickly and is minor. I do say, and there were some misunderstanding, and I think we heard about various things on the news at the beginning of the pandemic that you shouldn't take Tylenol, acetaminophen, or ibuprofen. The fact is that is not true. You can take those. You get the vaccine, you don't feel well, you can take them. You have COVID, you can take them. It is fine to have symptomatic support. The questions have also come up: can you get COVID? Can you get vaccines after having received COVID? As Dr. Subramanian said, you can absolutely get the booster. And even if you haven't been vaccinated before, you can get the first dose after having received COVID, and it's to your advantage. They would usually recommend waiting about 2 weeks until you're asymptomatic, but definitely something to pursue. There are reports, and there are several publications looking at myocarditis, that inflammation of the heart or the inflammation of the tissue around the heart, the pericarditis, after vaccines. Now, this is incredibly rare, and I have to emphasize this, very rare, most common in adolescents, and for some reason, boys more than girls. But but incredibly rare and really no higher than the rates of these conditions in the general population without vaccines. And we also have to take into account there's also the heart failure associated with MISC, and that associated with primary COVID infection. And so the risk of these associated with the vaccine are far, far lower than the risk that you would have of primary COVID. And so we recommend, again, this is something to follow, and even those cases that have been reported all recover. Now, one of the questions that does come up, and Dr. Subramanian alluded to this, the choice of vaccine. There is some uncertainty with the adenovirus vaccines, specifically the Johnson & Johnson is the one that comes to mind. Is there implications for myotonic dystrophy or any condition where gene replacement therapy might be considered in the future? An adenovirus is often used, or an AAV, to help with gene replacement, conditions like SMA, and other conditions where they're doing gene replacement. Adenovirus vectors have been used for those. Now the question comes up, if you've received one of those, and there are many different kinds, could there be something in the future that you wouldn't be able to receive a gene replacement if you received an adenovirus vaccine, as you might get an adenovirus infection in the wild type? And so this is uncertain. So if you've received Johnson & Johnson, it's okay. But it's something to sort of follow. And in the future, if there are trials for gene replacement, it's something to ask your providers and the researchers that you're working with. So I want to thank Mike and the Myotonic Dystrophy Foundation, my team. I have to thank Dr. Priebe and Dr. Sandor, who are colleagues of mine in infectious disease, who provided me with a couple of the slides. And I also just want to remind you, get the flu shot. We are seeing a lot of other viruses, rhinovirus, RSV. We are starting to see flu. Getting one doesn't mean you can't get the other. Thank you. And I'll pass over to Dr. Meyer for the rest of the presentation.
Okay, I'll finish things up. So as Mike mentioned earlier, my name is Hank Meyer. I'm a pediatric pulmonologist from Children's Hospital of Philadelphia. Are we able to, there we go. Okay, and I've had the privilege of taking care of a lot of patients with neuromuscular disease and focusing obviously on the respiratory component of their care, but thinking more broadly. So I'd like to address some of the more clinical questions, sort of outpatient questions that were asked. And there are these four. The first is, please discuss COVID-19 in children in general. And then what do we know about the effect of COVID-19 on children with myotonic dystrophy specifically? And what are the best ways for children with myotonic dystrophy to remain safe from COVID-19? And then finally, how can parents think about the risks for their children during the pandemic, specifically related to masking, vaccines, school, in-person fun and activities, and then being around other children, i.e. living your life? So let's start with the first one. So let's talk about COVID-19 in children. And in general, I think it's pretty clear that with a couple of exceptions, the clinical disease that we see in pediatric patients, irrespective of underlying diagnosis, is exceptionally less severe than what we see in adults. And I don't think there are hypotheses, I believe, for why that is, but I don't think there's a solid explanation. And I won't step too far out of my lane on this one because I just don't have a biologic explanation for that. But I can tell you that we don't see as many patients with SARS-CoV-2 infection as we do on with our adult colleagues. The condition is typically fairly short-lasting. Does not mean that it's not without some misery. But again, unlike our adult colleagues, we don't, at least at my hospital, the Children's Hospital of Philadelphia, have not had many pediatric patients admitted with SARS-CoV-2. Certainly nowhere near what we've seen in the past, and for lack of a better term, more conventional cold and flu seasons with more common viruses like influenza, rhinovirus, certainly, and adenovirus, and the big one, respiratory syncytial virus. Largely speaking, patients with pediatric patients will have a successful recovery and return to their previous level of function. And a lot of that has to do with the relatively mild infection, but also the fact that kids typically respond to infectious challenges, and when they have severe infections, typically bounce back much better than adults. The exceptions to that, however, are one that Dr. Graham had mentioned, multi-system inflammatory syndrome in children, which is a rare but still significant and not entirely understood syndrome where there are there's persistent inflammation in children that tends to affect vessels, something that we call a vasculitis, and it can still be successfully treated as an outpatient. At least at my institution, the patients that have passed with SARS-CoV-2, COVID, have had significant multi-system organ dysfunction, meaning patients that are quite sick to begin with. And that would, in a way, sort of fall in line with what our adult colleagues have seen, which is patients that have severe underlying disease, such as, at least in the respiratory standpoint, COPD, or patients that have severe immunodeficiency or diabetes mellitus have been a setup for having a more severe case. And so when we have the occasional pediatric patient that has severe multiple medical problems, then they are in fact at high risk of infection. Now, to be clear, I do not consider any neuromuscular disease to fall into that category unless there are other major complications. So, second question, what do we know about the effect of COVID on children with myotonic dystrophy specifically? Well, not very much, because we really haven't seen it. And unfortunately, or fortunately, that applies to most neuromuscular conditions that we see. And so what we can say is that to the extent that patients with myotonic dystrophy have been exposed to and become ill with SARS-CoV-2, that they're not really showing up in the hospital. And to the extent that they are, it's very rare. And the vast majority of patients will be able to do well at home and recover and move on with their life. Now, it's important to remember that SARS-CoV-2 is, at its core, it's a respiratory virus. We see other types of coronaviruses through the winter, but certainly nowhere near the same frequency as the SARS-CoV-2 virus that causes COVID-19. And so when I talk to my patients, what I point out is that it is another respiratory virus, and the approach that should be taken are the same things that you do every single year to try and mitigate the potential risk of contracting a respiratory virus. And one of the things that I found interesting is actually here at CHOP, there's about a 5-month period through the heart of winter when we saw no influenza or no respiratory syncytial virus in the hospital, in spite of fairly frequent testing for anybody that came in with a runny nose. And that's not because they went away permanently. It's because those viruses weren't being transmitted because we were socially distancing and isolating, which is obviously what was critical to try and manage the spread of SARS-CoV-2. So the point that I'm trying to make is that it is a respiratory virus, and it will behave like other respiratory viruses. And the approach should be the same that you would use for any other respiratory virus. The preference would, of course, be prevention, but when infection actually occurs, to focus on symptom management. And that would include, of course, using whatever acute respiratory management program you have designed for your child or for yourself with your clinician. So what are the best ways for children with myotonic dystrophy to remain safe from SARS-CoV-2 COVID? Well, that one's easy, and I think you already know the answer, and that is vaccination. It's the only valid and effective way of not preventing, but minimizing the chance of developing COVID from being exposed to SARS-CoV-2. And so beyond that, of course, one of the things that I think we all struggle with is this concept of social distancing, including masking. And that's certainly an exceptionally effective but frustrating way of helping to manage SARS-CoV-2 and spread. And so one of the other things that I think is important, that I think everybody in the public health realm would agree upon, is the importance of masking when you're in an indoor area with people with unknown SARS-CoV-2 status. So what does that mean? Well, if you're at home with your family and you know that they're well, take your mask off. And I think we've all done that through the pandemic. If you're getting together with your family for Thanksgiving dinner, one of the recommendations that was out there before this past Thanksgiving was, in spite of vaccination status, to consider getting tested. And so if you know the status of the people around you, which of course is somewhat controversial because that requires asking personal health information of those people around you, then you can be somewhat confident, if you know that they're not acutely ill or don't have SARS-CoV-2, to be around them without masks. The other thing that's important is this concept of what is an asymptomatic carrier. And as the name describes, that's somebody that has SARS-CoV-2 but's not showing the signs, or at the very least perhaps has very early symptoms that they may not recognize. And so I would turn that around to each of you and say it's exceptionally important to be honest about how you feel. If you don't feel well, don't say, well, gosh, I have to go to work, my colleagues are relying on me, or I want to go to this gathering, I've been waiting all week for it, and I feel okay, not great. Don't go. And it's important to be honest with yourself with that, and to be comfortable approaching other people who may appear to be acutely ill and suggest that they either put a mask on or perhaps consider removing themselves. And the final thing, of course, which I mentioned just a few minutes ago, is being aggressive in managing early symptoms when they occur. And this is, for the patient with myotonic dystrophy or SARS-CoV-2. I'm sorry, from SARS-CoV and SARS-CoV-2 infection, or really any other infection. The best chance of having a good and fairly smooth outcome is to begin acute management as soon as possible. And if that requires getting assisted therapy, airway clearance therapy, or perhaps additional care, do it as quickly as possible once you begin to get sick. The sooner you wait, or the sooner it takes for you to acknowledge the fact that you're sick, the harder it's going to be to get through the illness as smoothly and as easily as possible. So is that one more slide. So how can we live our life? Meaning, how can we think about balancing the risks of exposure and contracting SARS-CoV-2 during the pandemic? So I was mentioning in the last slide, it's managing risk, and it's virtually impossible unless you stay away from everybody else to eliminate risk. And so managing risk, I look at as taking reasonable precautions, but still allowing yourself to enjoy life. If you go outside and you're outside and there's nobody around, or nobody within, dozen feet or so from you, take your mask off, especially if there's a bit of a breeze. If you want to be around other people, as I mentioned, get a sense of what ask them what their status is. If they're vaccinated, there is an exceptionally small risk of passing between two people. It's not zero. And so if you want to eliminate risk, then don't go outside. There's very little else you can do to be completely certain about not being exposed to SARS-CoV-2. And then reasonable precautions. we're all sick of masks. Masks are terrible. They suck. It's a miserable thing to have to wear all day, but boy, they do work. And so if you want to be without a mask, be outside and be around people, or be inside around people who are fully vaccinated and or are tested and are clearly negative and have no active symptoms. And if that's not possible, then wear a mask and try and avoid crowded environments. And I think one of the things that's important to keep in mind is that at some point this will be over. We will get back to some, whatever we want to call normality. I suspect that a lot of the practices that we've used to help get through the pandemic successfully will probably in some way, shape, or form be integrated into our standard practice, such as, being on a subway in New York City. If you're crammed in around other people, are you going to be comfortable in the future not wearing a mask? Don't have an answer for that yet because we haven't gotten there. Are you going to be comfortable being in a crowded environment, getting entertainment, or at a restaurant, or another type of entertainment facility like a bar? These are all questions that eventually we'll have to answer for ourselves, but we may be able to utilize some of the lessons and practices we've learned in working through the SARS-CoV-2 pandemic to help us mitigate risk in the future, remembering that, as I said before, and this is should be clear, SARS-CoV-2 is one of a number of respiratory viruses. And now that this winter will be more in contact with each other, there will be the possibility of seeing other respiratory viruses that we see every year. And it's important to not lose sight of that and not just focus on the fact that there's one very prominent respiratory virus. So I'll stop there, and I believe we open things up to questions for all four of us.
Dr. Meyer, thank you so much. This is Mike, your MDF program director again. And yes, I would like to invite all of our panelists to reveal their cameras and unmute themselves as they respond. But we have so many questions from our audience. In addition to all the great information you have provided, we still have some questions and concerns from the audience. So in no particular order, I am going to go through these questions. I will share them with the panel, and panelists, feel free to simply respond, claim a question, add to anything your colleagues may say. And we have this incredible panel for the next 30 minutes or so. And we will do our best to cover as much ground as we can. One of our first questions is related to long-haul COVID. The audience would like to know if we have any kind of a late update on information related to long-haul COVID.
I see quite a bit of long-haul COVID, so I can take that. We are still studying long-haul COVID, but there is a significant percent of people, even who have mild COVID, who develop long-term symptoms, which can include fatigue, cognitive difficulty, and a variety of symptoms, dry, multiple symptoms, and it lasts for quite a while, at least a month to meet the definition, but many still have symptoms 6 or 12 months down. Those who had severe COVID-19 often do have pulmonary side effects or maybe some effects on the heart, which was more related to the COVID-19 itself. But the long-haul COVID symptoms from even mild COVID-19 is thought to be more sort of an inflammatory trigger, and that's what we're studying. There are various smaller studies that have collected information and samples from people over the last year, and now there's a huge NIH trial of which many centers are part of, and Stanford is one of those, but where we're going to follow patients over the next several years and really understand the triggers, the risk factors, the immune recovery, and where those gaps are so that we can come up with good treatments in a standardized way, and how to really support people and get them better. But there's still a lot of learning that's going on, but at least the NIH has put a lot of money into trying to understand this. Happy to have somebody else take on.
Thank you, Dr. Subramanian. That's very, very helpful. Dr. Graham was able to respond to a few questions that we've had already related to boosters. Dr. Graham, would you mind talking about sharing with the audience verbally what you've said about what we expect for boosters for children?
Yeah, so I mean, one of the questions came up in terms of, boosters are currently only approved for those 18 or older, and we are anticipating, actually, hopefully soon after the first of the year, that we'll start to see it move down in the age groups. Those are all being tested, and the question always comes up in terms of how many children have these been tested on. It's in the tens of thousands with each of these trials, and now, as you've seen with Dr. Subramanian's presentation, literally in the millions that have received it. So, yeah, we would anticipate probably in the 12 to 17 age group first, and then they will probably recommend after in a similar interval those who are under 12. And there actually are also, by the way, for those children under 5, there are trials underway right now.
Thank you, Dr. Graham. We have a question about severity of reaction to vaccine. Is it known whether there's a correlation between how protected one is against the virus and the severity of one's reaction to the vaccine? Is there any correlation?
No, that's not very well correlated. Yeah. Sometimes we hope that people who, if you have a reaction, you think, okay, well, I have a really good immune response and I'll have a better immune profile from it, but it's not as well correlated. So even if you didn't have much reaction, you can rest assured that you likely still have good protection.
Thank you, Dr. Subramanian. Dr. Mankodi, I wonder if you could answer this question. We have an individual who is diagnosed with myotonic dystrophy, an adult. They have had COVID-19 and they have had vaccines. And subsequent to getting COVID-19 and then vaccines, they experienced some pain in their extremities. And they're wondering if those are related and if they should do something about it. So someone with DM has had COVID-19, has been vaccinated, now having pain in their extremities.
I think this is a good question. Individually, just addressing the question for one particular individual, the pain could be coming from a variety of different reasons, but in general, lingering muscle pains that continue even after the acute phase of infection has passed is a manifestation of long or post-acute COVID-19 syndrome. There could be some medications that also could be adding to the symptom of muscle pain. It could be just that they have had acute infection and then recovery period. Having underlying neuromuscular condition could also make an individual to feel the pain. So there are a variety of different reasons, and I think medical evaluation would definitely help, just tweeting all those things out. Because pain is such a general symptom. There are so many different questions that I would like to ask my patient. So I'm just giving very general background, just broad overview. But it's a good idea to talk to your doctor about it.
Thank you, Dr. Mankodi. Dr. Meyer, we had a question about monoclonal antibodies. I wonder if you could speak to monoclonal antibodies. Specifically, the individual says that You mentioned airway clearance therapy in the treatment of COVID-19, but could you talk also about monoclonal antibodies?
Not with any precision or expertise, so I'll have to defer answering that perhaps to Dr. Subramanian.
Dr. Subramanian, do you have any thoughts or comments on monoclonal antibodies?
Sure. I think monoclonal antibodies are one of the most, I guess, most effective treatments if they're used up front. If you use them early, they can really help prevent hospitalization in people who are higher risk to develop severe COVID-19. So I think that if you have, as I said in the presentation, if you have any, if you have any symptoms, if you're exposed, you really should go get tested so that you can get monoclonal antibody early, and that I feel like it's been underused and really can prevent hospitalization in patients, as I said, who are at higher risk of developing symptoms. And we can use it early in disease, post-exposure prophylaxis. And I'm getting text after text right now because in fact, it's been approved. One of AstraZeneca monoclonal antibody just this afternoon got approved as preventative antibody for people who are really high risk for, even before they are exposed as a prevention. So there are multiple ways of use, and I think it is something we can use, but it doesn't replace vaccination. It's still better to get vaccinated and not to have to deal with all these types of treatments if you don't have to.
It's also helpful to know that the monoclonal antibodies aren't approved. There are only certain ones that are approved in children, and they only go as low as 12 years of age, and you also have to be at least 40 kilos or over 80 pounds. So, yeah, and as I said, I think we're going to continue to hear about treatments, whether it's the oral drugs or additional sort of targeted things. They're not a substitute for the vaccine. Prevention. Those aren't intended. You want to prevent it through vaccination, which helps not just you but everyone, as opposed to wait and get infected and then receive the treatments.
I just want to emphasize for our audience that we see our entire panel nodding at the mention of vaccines. This has been emphasized in each of their presentations and has come up in their responses to so many questions. I think I'd like to turn to Dr. Mankodi for the answer to this question, but I do want to add a little prefatory remark. We had a question about whether DM, myotonic dystrophy, is considered immunocompromised. And I just want to note that in several of our previous presentations, our panelists have, what I believe have explained that the variable symptom profile of myotonic dystrophy and the variability of the severity of those symptoms can affect, DM can affect people in such different ways that people with DM, different individuals may have underlying issues that could put them at higher risk for things. But I feel like I was hearing that myotonic dystrophy itself is not some kind of higher risk category for COVID-19. But I want to turn to Dr. Mankodi first on this, and then maybe Dr. Graham. Dr. Mankodi?
Yeah, sure. So I think we are discussing about immune system per se. So one features that has been described are modest levels of decrease in the gamma globulin levels, which are protective proteins in our body. But there is no evidence. We do not have data that myotonic dystrophy gene defects per se lead to immunocompromised status. So I hope this answers the question.
Thank you, Dr. Mankodi. Dr. Graham, could you speak to that as well, especially in the pediatric population?
Yeah, we don't necessarily, I mean, the things that when and I think Dr. Meyer alluded to this as well, is that, we don't necessarily think of myotonic dystrophy or most of the other neuromuscular conditions really having an associated compromised state. Like, you should be able to mount a response. The children we've seen hospitalized with severe infections have all been either had other conditions or they're on other medications that suppress their immune system. And that's usually not even, not even really low dose steroids, because in fact, actually steroids are often used with acute COVID. So it's other sort of illnesses that would require immunomodulatory therapy, certainly cancer therapies, but other, and I actually saw in the chat that there's something about someone receiving etanercept for ankylosing spondylitis. It's things that would really alter your immune response would be things that we would worry about and put you in the higher risk category.
Thank you, Dr. Graham. Dr.
Can I just
Subramanian,
add on a little bit to that, please? While it's not officially an immunodeficiency, I like to think of patients with neuromuscular disease as having a deficiency in their ability to clear infection. And so that, I feel, is even more critical than whether you have a cellular immunodeficiency, is recognizing that there are increased respiratory secretions, which would happen from COVID, from rhinovirus, adenovirus, any of the respiratory viruses we see. And more importantly, recognize that something's not right and start an aggressive treatment plan to help get on top of secretions and symptoms before it's worse. That, to me, is going to save the day much more than any other medication that's used.
Thank you all so much for that. We have a kind of philosophical sort of question, I guess, about trust. One individual has shared that they have received information from their sources which seem very much at odds with what they have heard today, what they read in the CDC and other known and trusted sources. And so their question is about trust. Whom should they trust? How can they vet information? How can they access and interpret data so that they know how to make the best decision for themselves and their family at this time?
Yeah, I mean, as I guess as an advocate for your loved one or yourself, you really have to feel comfortable with the information you're getting. And it's true that the media has been filled with varying information, and even our social media feeds can give us a picture that's completely different from what you hear. And yet I think you have to trust your care team and the people who are providing care to you in order to get the best care for you. It's really a joint decision, and these types of information can be shared through conversations with your care team. But I think you really have to be careful that a lot of the things that go around on social media are not properly vetted. And we know when you look into that, you find people have their own agendas for why they're sharing this. And there are, lots of folks who are trying to sell their own snake oil and, things that really aren't going to help people and aren't science-based. And we really have to try to stick with the facts and understand what's going on. I wish people could walk through our COVID ICUs and actually, because of patient privacy, we can't share what's going on in great depth in the hospital. But if you walk through there, you'd see the heartbreak and the problems that you see from COVID-19, and really understand why healthcare providers are encouraging prevention. And I think that's where
and I would say, I know Dr. Meyer's point where, you work with your team to help support through other illnesses. I mean, if you have flu or you have RSV or you work with your primary team to, implement the non-invasive supports, the secretion clearance, all of these. You work with them and like, should we get the flu shot or not? I think as we even think about, and I think about Dr. Mankodi and the research at NIH and elsewhere, looking at, how do you, long-term, are there gene therapies for myotonic dystrophy? A lot of you would work with your primary providers and teams to say, I'll do anything to address my myotonic dystrophy. Well, you have to remain healthy enough. If you get COVID, you may not benefit from something that's on the horizon. And so work with your primary teams as you would, addressing your primary needs as they think about you and COVID as well. I think it's, you'd help yourself or your family member address the other issues, and COVID should be the same.
If I may add something, is just at the philosophical level again. It seems encouraging questions. So ask questions as you're doing today. Communication, knowledge, getting the hardcore facts, because those are going to help us. And I think I really appreciate what we are doing today, we are discussing. So please just feel free to ask us questions and have open-minded conversation about the topic, because COVID-19 is evolving. We're still early in the phase of the disease. We still don't know much about it. It's only through knowledge, data sharing, generating hardcore data, talking to as many people, I think the trust will eventually form. So asking questions, I really applaud this event today. And I think we're all getting an opportunity to learn from each other.
Yeah, I want to add to what my colleagues here have mentioned, and I just want to take everybody back about now almost 2 years. We had this infection that nobody had ever seen before, thus called novel coronavirus. And I think it's pretty clear that for the first maybe 4 to 6 months of this, our adult colleagues were doing a tremendous amount of work being creative and trying to come up with novel approaches that weren't necessarily based on hard science, because there wasn't any hard science. And so there were a variety of different things that were tried, some with success, some without success, some of which have been completely disproven and abandoned when the science showed that they weren't effective. What I think is critical is not to go back and repeat the mistakes, not mistakes, but the work that was done in the past that was shown not to be effective. And so to answer the question very directly, trust where the data are, trust what the science and what the evidence shows. And if somebody says here, gosh darn it, I was reading about this and I found this medication that supposedly prevents you from getting COVID. Well, what is that based on? Is that somebody's conjecture, or is that based on somebody's experience with hundreds of patients and validated by review through the medical through colleagues? One of the things that I think can be troubling for people outside of the medical field is a trust or perhaps distrust of conventional medicine. And for some people, that is something that is an issue. And I don't have a good way to get past that, other than encouraging you to trust science and trust evidence.
Thank you all so much. We have a great deal more questions. I'd like to turn to Dr. Mankodi. We have several questions from individuals living with myotonic dystrophy type 2. In your presentation, of course, you addressed the different types of myotonic dystrophy. And these individuals are wondering if there are any specifics that should be known for them. So if you have DM2, what should you know specific to you, specific to myotonic dystrophy type 2, about risks of COVID, treatment of COVID, and so on?
So again, I do hope that, when we were discussing just the background of COVID-19 and myotonic dystrophy, it's not as much as myotonic dystrophy or type of myotonic dystrophy. It's in an individual, as the disease is variable. It's an individual disease. It's like ice crystals. No two ice crystals are alike. So overall, just looking broadly, type 2 is less common, less severe. Respiratory complications are uncommon. But there are other things that generally affect community. For example, heart condition or COPD or some other lung conditions, or poorly controlled diabetes or high blood pressure. I think they all will put us at risk. So it's at individual level. What are the other medical conditions that you may have? I would just say that it's not per se with the DM mutation. It's more to do with what other comorbidities that an individual has. That's going to put us at increased risk. But again, I think, as all of my colleagues have said today, vaccine is the best defense that we have against this pandemic.
Dr. Subramanian, we have a question about vaccine, sort of the shelf life of vaccines and how long they hold up. There's a question if individuals with myotonic dystrophy will see the vaccine effectiveness decline faster than individuals without myotonic dystrophy.
That's a good question. I don't know of any data that would support a faster decline in patients with myotonic dystrophy. You know, it's people who are really very severely immunocompromised in a certain way, as Dr. Graham said, either through chemotherapy or on transplant anti-rejection medicines, for example. Even in bone marrow transplant patients, up to 70% do get some response to vaccines. So it's not that it's even all or none when you are severely immunocompromised. So I think that we have very specific reasons to think for those people in the category who need a third shot within a month, that's a different category than people with myotonic dystrophy. So I don't think, the short answer is no, there's no data to think that they will decline faster, as far as I know.
Thank you very much. I guess I'll make this an open question, but I think Dr. Mankodi may have some insights. So I'll ask you first, Dr. Mankodi. The research that's been done to develop mRNA vaccines for COVID, has any of this research been adapted or could be adapted to investigate treatments or cures for myotonic dystrophy?
This is a fantastic question. Oh, wow. So in general, yes, I think this question is pertinent because, as you guys know, field is advancing towards using RNA molecules to target the gene defect in myotonic dystrophy. There are several different approaches being taken. One particular molecule actually is under trial right now. I do believe that the technology advances that have occurred during the past couple of years in the vaccine development, many of those could be adopted to develop therapeutic molecules for myotonic dystrophy. The current challenge, however, that we have is muscle is the largest organ in our body, and that is primarily affected. So we need to get those RNA molecules inside the muscle. So that is the challenge to the field right now, as opposed to vaccines. But yes, I think we all take this in spirit, and yes, we are all learning from each other. And hopefully in the coming years, we may see improved delivery of the RNA molecules to the target organs in our disease.
Thank you very much, Dr. Mankodi. I think either Dr. Meyer or Dr. Graham could address this. I believe Dr. Graham's presentation actually addressed this already, but if we could reinforce this a little bit. We have an individual who has a minor child who had COVID-19, and the parent wants to know if the child should still get the regimen of vaccines, and if boosters become available for the child, should they also get boosters?
Yes, so yes, and I think all of us said, you know, if you have COVID-19, doesn't matter your age, if there's an approved vaccine, so basically anyone 5 and older, you should receive the vaccine even afterwards. They will often, recommendations are, you know, at least 2 weeks after. If you did receive monoclonal antibodies, they actually recommend 90 days after receiving the monoclonal antibodies, because those, by the way, they do deteriorate. Those, you know, it's you get your infusion and it dissipates over time, and so they recommend waiting 90 days, 3 months after monoclonal antibody to get the vaccine. But absolutely.
I agree completely.
Thank you, Dr. Meyer. We have a few questions related to timing. I think both Dr. Subramanian and Dr. Graham shared information about schedules, but I wonder, maybe Dr. Subramanian, could you refer us to the resource where individuals can check for the schedule for vaccines?
Sure, it's on the CDC website. That I would say is probably the easiest. I think that's where I got the table. And basically it's the first 2 doses are either 3 weeks apart or 4 weeks apart for the Pfizer and Moderna, and then the booster is 6 months after. J&J is 1 dose, and then 2 months after you can get the booster. So, and the booster can be mix or match. And I would recommend actually getting either Moderna or Pfizer as a booster.
Thank you. We have also received a few questions about immunity increasing drugs and other kinds of medications or drugs or treatments that are alleged to prevent infection from COVID-19. I wonder if you could speak to any of those. There are a few named here. I'm reluctant to sort of throw these names out, as I don't think that's none of these names appeared in any of your presentations, but if individuals are hearing about these things, what should they be doing? Are any of these valid? I don't know if any of you would like to speak to that.
What is the question? I don't quite understand.
There are some individuals who believe they've been told that there are some other drugs that are not vaccines, that are not the ones listed by the CDC, which individuals allege can either prevent COVID-19 or cure it. If individuals hear about this kind of thing, what should they do? How should they deal with it? And are you aware of any other drugs or things that can prevent or cure COVID-19 that have not been discussed?
I can say there are a lot of things that have come up anecdotally, and people, and the problem is that when you can have mild COVID-19 or you can have asymptomatic COVID-19, and it may be that you got the mild illness or were asymptomatic, not the medications you were taking or the supplements you were taking, but because that was just what happened. And unfortunately, people have made these associations and are promoting these things. I would say that yes, of course, healthy nutrition, vitamins as needed, and exercise, all of that is good but it doesn't prevent COVID-19 in and of itself. Really, this is an infection, and we really have to get targeted treatment for it. And so really what we do have to go with the scientific studies and these are the things that we're recommending.
And I think Dr. Meyer alluded to it earlier as well. He talked about that there have been studies now and shown that things don't work, and that we don't necessarily, at the outset, people were trying all sorts of things, and it's been shown that some are actually detrimental, that they cause problems. And I think it's important to recognize that as you're talking about trust, is to go to your providers and if it's not something that you see on the CDC website or hear about approvals, then you really have to question, is this going to harm me as much as it may help me?
Thank you, Dr. Graham. And now we have been on for quite a bit of time. We've taken so much of these extraordinary panelists' time, and they have shared so much information, and we're very grateful. We do still have questions, but we at the MDF will do our best to respond to all of those individually following this presentation, and individuals are still welcome to ask us questions. We'll do our best. I would love to turn to the panel now and just ask if you have any concluding remarks, final remarks that you'd like to share with our audience today.
Vaccinate, be aggressive in starting clinical therapy, and partner very closely with your clinical support.
Absolutely. And families and the caregivers really need to get vaccinated also to protect our patients. I know our families would do anything. They would sacrifice so much for the sake of their loved one. So this is one of those things that really you need to do, is get vaccinated for that sake too.
And I think as we heard Dr. Mankodi talk about the prospects of, myotonic dystrophy treatments for the condition itself in the future, is that we have to keep you as healthy as possible now, so that you'll benefit from that in the future.
I think we are already doing well. Myotonic Dystrophy Foundation has been spearheading, just doing the leadership role in getting the community together. And I think we must be doing something well, because we are not ending up in the hospital in increasing numbers. So please continue what we are doing, continue working with the doctors, continue taking care of yourselves, and get vaccinated. Thank you so much. And thank you, Mike, for your really wonderful leadership today.
Thank you all so much. Our panelists today have been Dr. Hank Meyer, Dr. Aruna Subramanian, Dr. Ami Mankodi, and Dr. Rob Graham. We're so grateful to all of you. This will be recorded. You'll be able to review the video in future. We will share their PowerPoint slides as well, all of this incredible information. Thank you all so much, and I hope that you all have very happy and safe holidays.
Thank you.
Thank you.